As you can see, this is the gradient echo contrast enhanced MRI, which I've activated. Just to run you through the functions a little bit of the tool rack. All my different imaging modalities, I'm having them all lined up on the side, and through the presentation you will see me activating or deactivating different imaging modalities. And I have tools here like measurement, curved measurements and linear measurements and angles I can measure. I have cropping tools, volume exploration tools, cut tools. You will see me using those during and the others during all the presentations. I have tools for visualization, for data co-registration. Most of the data you're going to see tonight will be multimodality data, which is data that is consisting of CT and MRI and the different subgroups of MRI like MRA or MR venography. So in that interface, we have different tools to co-register the different imaging modalities. And then there's tools for segmentation, like volume cloning and manual outlining in case you have to, or algorithms to give you a threshold-based segmentation, sometimes completely automatic segmentation, sometimes semi-automatic if you have to refine something. And of course you can report, you can make snapshots, you can make snapshots and print snapshots which you can take to the operating room of the different steps of the planning procedure. You can print them also in red-green stereo, so if you want a stereo snapshot in the operating room, we're doing that all the time in Mainz. You can generate them during your planning session and then hang them onto your wall in the operating room. So, and you can make movies, of course. You can record everything you do and play it back and turn it into some different formats of videos. So, this is the gradient echo contrast enhanced MRI. And you can see a lesion there, a meningioma. Of course, I also have to say, unfortunately, this screen is a little bit far away from all of you. There was constraints in setting up this room, so we will all try to magnify it accordingly a little bit. And you see a meningioma here. And you see the carotid arteries, obviously, in the vicinity of it. And you see the chiasm and the optic nerves, the left one being pressed to the side a little bit more than the right one. And you can see the pituitary stalk. And as we all know, the pituitary gland enhances usually if you give gadolinium. So in this case, we need to differentiate a little bit between the meningioma and the pituitary gland. So the meningioma is sitting there, reaching a little bit onto the plenum sphenoidale, then the tuberculum, and into the pituitary fossa a little bit. And the pituitary stalk is there, right? So we can see the contrast enhancement is pretty much identical, but probably this is the pituitary gland somewhere there, and the meningioma is on top. So we use some semi-automatic segmentation to segment the lesion on top, making use of the threshold, which is between the upper part of the lesion and the frontal lobes, and we use some manual refinement between the gland and the meningioma. And so you can see already just working with 3D planes of the MRI is already an intuitive thing. I can easily and almost instantly and simultaneously access the different planes and extract quite a bit of information there already. So now we have segmented the lesion, the meningioma. I'm going to show you this in big, of course. This was the result of our segmentation process. All right. And then there would be the pituitary gland underneath, the pituitary stalk. Okay, that's one thing. Now, what else is interesting for us surgeons? A lot more, of course. The next thing is the chiasm and the optic nerves, which we have segmented. You can see them on the MRI. So we employed a manual segmentation method. It takes you about 15 minutes. They don't look super nice in terms of their outer appearance, but they are accurately placed. And then you can see already that the lesion is pushing the left optic nerve much more than the right, which was also reflected in the clinical symptoms of the patient. He had more visual disturbances on the left than on the right. So in the considering from which side to approach this, as we will discuss in a little while, this of course plays a role. So that's one thing. And then the next thing would be the blood vessels. So we also scanned an MRA, and we co-registered the MRA with the MRI. You see it's getting a bit more complex now, but that's what we want, right? So there's the lesion, close proximity to the carotid arteries, as we would expect. And now, of course, the last thing that we really want to know is the spatial relationships to the skull base. So we also did a CT scan, and we co-registered the MRI and the MRA with the CT. So let's look at it close up. So there you go. So I cropped the skull base sagittally. Now you can see this is the relationship, right? The skull base coming in, the lesion sitting right there at the planum, at the tuberculum, and extending down into the pituitary fossa. So you see nicely the pituitary stalk. So you see I'm kind of using all volume exploration tools, as we like to call them. If you want to crop the arteries a bit, because you want to see the relationships to the skull base a bit more, and you don't want to be obstructed by the left ICA, of course I can take it away, as I just did. And this would be looking at it straight from lateral now. Okay. I'll put the vasculature back on. There you go. So you see, I'm working naturally in 3D all the time. So now how would you operate this? So as we said already, the tumor is in between the optic nerves. And since it's compressing the left one more than the right one, our thinking was, let's operate from the right, because then you don't have to deal with the already damaged left optic nerve while dissecting the lesion. You hit that nerve on the left side at the end of the operation. So we went from the right. So you could go pterional, or you could come a bit more anterior. You can go subfrontal. What we like to do in this case is we decided to go for a supraorbital approach through an eyebrow incision. It was a guy in his 50s. He had thick eyebrows. His hairline was way back. So we thought this would be the right thing to do. So of course with this software you can try any approach and just see if it fits your requirements and if you can access the lesion. So let's try the supraorbital approach. I'm having the CT. I have a virtual drill. It's like a voxel editing tool. We are dealing with voxels, which is three-dimensional pixels. And that tool is editing them in real time. So positioning the patient a little bit. And I can adjust the size of this. I want to have it a little larger than we would usually have it. So we are making a burr hole behind the temporal line. Yeah. And then we are taking that craniotomy over the supraorbital rim. Now the interesting thing is we have limits medially, of course. One is we would like to avoid going into the frontal sinus, which is here. You can see there's a crop box. So if I bring the object towards that crop box, it automatically crops. I can crop through the whole thing. Yeah? So cropping only through the anterior parts of the CT would give you a nice overview over the sinus. And also here is the porus of the supraorbital nerve. So I also don't want to go as medial as that. So, but something like this is already pretty sufficient. It's probably even a little larger than we did it. We didn't go as temporal, but it's okay. So then you can simulate. I'll make it a little bigger. We can simulate taking the protuberances of the orbital roof away a bit. We did that while staying extradural. And then the tabula interna of the bone, we removed everywhere. Yeah. So you can already see the lesion is in the back. Being there somewhere. I can do a measurement, by the way, just to demonstrate that. From here to there, it's 40 millimeters. We did a smaller craniotomy in that case, but it doesn't really matter now for the sake of demonstrating that. And now I'm coming in. So that would be the way, pretty much very accurately, the way we were encountering this lesion during the approach. Of course, you will say, hey, where's the frontal lobe? If you don't have a frontal lobe, if you don't have a cortex, we'll make one. So you see live a segmentation process. This is the cortex. This is my MRI. I'm employing a segmentation tool. I go to extract component. I have a couple of threshold settings. Yeah, so a couple of things like that maybe. And then I go extract. And there it is. So I can change that a little bit. I can give it a little bit of a color if I want. Okay, let's make it maybe not green because the lesion is already green. But let's make it maybe, I don't know, something like that. Of course, immediately now I can put back the CT. I can put back my MRA, my optic nerves, and my pituitary gland. Even have a skin surface, you don't really need now. And the tumor. So again, here's my opening. Visualization. So for the sake of you see, this is the real thing now. No prepared stuff. This is how it works. So I'm cropping that a little bit for the sake of speed. And so this is the CT. And pituitary gland. Good. There is my frontal lobe. So what I can do is I can do something like simulating gently the way the retractors would come in. Okay? Gently, okay? There's sometimes you will see now when we're working under higher magnification, you would like to have that magnification, you would like to have that information of surrounding tissue in there. Otherwise, it feels a bit too empty when you're in there. So, again, this is the lesion. And what do I see? I see the right optic nerve. I see the ICA. And now let's start removing this guy. We started to remove at the plenum. And then coming towards the tuberculum there. So with this line of sight, you can pretty conveniently remove all that. There was a nice subarachnoid plane to all the, I mean, you can. The concept is, can you reach it? Can you reach it? Do you have a blind spot somewhere? The point is, I can see that with this approach, there would be a little bit of tumor left on the other side of the tuberculum. And what we had to do also during the surgery, because we wanted to remove that inferior part of the lesion completely, including the dura, we drilled that. So you can see, you can drill the plenum and the tuberculum, and this is already the most inferior extent of the lesion. So by doing that, by drilling the tuberculum a little bit away, you don't have to unlock the optic nerves by opening the canals of the optic nerves. You can pretty comfortably, through this approach, take this guy out. So that's why we decided for that approach. In about skin to skin, less than 3 hours, the lesion was removed completely. Okay, that's one case.
We're going to be switching cases, so it's going to take about a minute to load the new case. So are there any questions for Dr. Kockro before I introduce the next speaker? We have someone with a microphone right there, Mike. You can take off the glasses, Mike. You look very cool, but you can take off the glasses.
Thank you very much for the presentation. What I want to ask you is that how can we make the visualization of the vessel automatically or by hand?
The vessels you saw were MRA, magnetic resonance angiography. As you know, the data is already pre-segmented from the scanner. All you see is the bright white signal of the MRA. So since it's a volumetric image, you load it, and the 3D reconstruction is automatic and instant.
You have to make it manually, and
no, for the MRA,
make automatically?
Completely.
Okay.
It's not at all. You come to our booth tomorrow, I can show you the raw data. I mean, it's typical MRA data, which is bright white, and the surrounding tissue is pretty much blended into black.
Well, the other question is that we have seen the big vessels, but we know that, for example, in this region are the hypophyseal branch of the A1. It means that in this region we can see the small vessels here or not? You
can see as much as you can see on the source data. If you can see a Heubner or any hypophyseal branches on your MRA, it will be reflected here. There's no loss of data, but if the source data doesn't show you those small branches, this software cannot create them out of nowhere.
Okay, thank you very much.
You showed some manual segmentation.
Right.
So this means that the operator in setting up the device, setting up the case, must, as it were, draw the line between the tissues. In effect, indicate the plane of the two tissues, correct?
Okay, there's different scenarios.
My question is whether there's any inaccuracy introduced in the manual segmentation that has to be performed on occasion, as for instance between the pituitary, the tumor, and the optic nerves, as you referred to in this last case, and if so, whether that really makes any difference clinically, as the individual, the surgeon, I would guess, traces out the difference between the two tissue planes prior to utilizing the dextroscope.
I would say you can roughly say there's 3 layers of modes of segmentation. Number 1 is the easiest one. You have a lesion which is clearly outlined to the surrounding tissue. So there is an algorithm which gives you, based on a threshold, the lesion automatically. If you have a bright ping pong ball in the middle, a metastasis in the middle of the brain, you can have that instantly in 3D, and the surrounding tissue can be turned transparent. The second one is you have lesions that are at some parts, like this meningioma, at some levels they differentiate themselves towards the surrounding tissue clearly, and in other parts they're not, like here. So then you take the same method of segmenting, and you will get something that shows you a structure which is the tumor, but also the adjacent stuff which has the same intensity. Then you take those tools, those voxel editing tools, and you take the plane of the MRI in the backdrop, and you have the lesion, And then by moving the plane a little bit, you can pretty easily see what is the lesion and what is the stuff that I don't want. And then you go manually, and then you take away the stuff that you think is not part of your target or part of that. And then the third layer is, and there's also the tools for that, which is lesions that basically not lesions, which is anatomical structures that you can only see with your eye because you're trained to see them. Like this optic nerve is very hard to see. It's just a little bit different on the gray scale compared to the surrounding. So even if you try that algorithm, you will just get fog. For those cases, you take a manual outliner. So I haven't shown you that, it's not enough time. So you outline in 3D. Here you don't outline like you're used to on a 2D kind of thingy, but you will see the outlines reflected in 3D above a 2D plane.
I understand. My question was whether this had caused any clinically significant inaccuracies. Obviously, outlining it by hand is not going to be absolutely perfect, but does it make any difference?
Does it make a difference in terms of...
Clinically speaking, in terms of your resection or anything of that sort?
As you saw here, our overall experience is if you have the structures segmented and you've gone virtually, you were flying into the structures and they were there, you have a feeling, you have a certain déjà vu effect, you have an increased confidence when operating.